morning, everyone. Let's pick up from where we left off in the previous lecture, 31, with the discussion of the development of the skeletal system. Setting my pointer here. And we had covered the general information on how flat bones and long bones develop two different methods, intramembranous and endochondrial, and followed that through not only the cytogenesis, but the histogenesis, morphogenesis, and reached this slide at the end of the previous lecture. And now we make the transition to discuss the axial and the appendicular skeletal systems and a little bit of additional information on those skeletal system structures in the subsequent lecture. So we start first really focusing on the axial skeleton, the vertebra and the skull. In this lecture, we don't focus specifically on the sacrum and the coccyx, which are other parts of the axial skeleton, but they follow a similar model as we'll describe here, but obviously there's distinctive morphological pressures on them to develop differently than the individual vertebra that we'll discuss now. We started the previous lecture reminding ourselves of the somites and what that represented on the surface, and internally in the middle layer of mesoderm and mesenchyme. Talked about the formation of the dermatomes and the scleromyotomes, and the sclerotomes splitting off basically from the myotomes. And now we're focusing on sclerotomes for the skeletal system development, specifically here, of course, the vertebral column. And what we recall is there is a roughly segmental origin and structure. Let's see. Forgotten how to. There we go. It was scan converting as it sent it up to the top there. The dermatomes represented segmental development, and now as we look at the sclerotomes forming the vertebral column, we remind ourselves that if you have segments, there's an intersegmental portion, and what's going to happen here is a segment above, half of a segment above, and half of a segment below are going to join together to form a distinctive structure and have a special relationship with the intersegmental vessels, and of course the nerves that have branched segmentally, not only related to the neural crest cells, but also to the outgrowth of the efferent axons of the spinal cord. Thus, the caudal half of each cranial sclerotome, so the upper one, its lower part, is going to form a special relationship with the upper part, the rostral or cranial portion of the caudal sclerotome. So we'll see that in illustrations in a moment. So they're going to join together. These are basically intermingling migratory mesenchymal cells. And we'll see that one part becomes condensed. The cell density is very high. The cellular to extracellular matrix ratio is a very high value, whereas the other component contribution is going to have the opposite, lower cell density to extracellular matrix. So they come together and I'm sure have a little bit of chemical communication, and these two, the cell dense and cell sparse portions, fuse, and they incorporate the intervertebral tissue, form a cartilaginous vertebral body that ultimately becomes intersegmental in origin. So a little bit from one segment and its adjacent segment contribute to the formation of a vertebral body. or at least the primordia of the vertebral body. So now we can transition over to discussing the vertebral column, and we'll spend a bit of time on the ribs also. The ribs are obviously segmental, so we can now even imagine just a condensation of mesenchyme that differentiates ultimately into the ribs at each segment in the thoracic region. We remind ourselves that the notochordal process is present here, just ventral to the neural tube, spinal cord developing, and we had informed ourselves early on that it does persist into adulthood as the nucleus pulposus of the intervertebral disc. Wherever there isn't a nucleus pulposus throughout the length of the vertebral column, of course the notochordal tissue disappears. The sclerotomes, the sclerotomal cells will proliferate to form the intervertebral disc, contribute by the notochord, as we had mentioned, and the vertebral bodies will also form from this differentiating sclerotomal cellular tissue component. Thus, we'll take a look at this figure 15.7. We see in the panel on the right we have a transverse section. The panel on the left is a transverse section through one of the segmental areas, and intersegmental areas, because we see the intersegmental artery branching from the dorsal aorta. This is at about 4 weeks, and the arrows are indicating the direction of growth of the dorsal surface of the embryo itself, rapidly growing. Come on, mouse. This movement with the enlargement of the neural tube and is related also to an expansion of the, let's just call it mesodermal component, the middle layer. In other words, the sclerotome and myotome tissues are continuing to develop to form these portions of the body. And the horizontal section shown here, taken at this plane in panel A, reflected here as an illustration in panel B, and we're looking from the top. First we orient, we see the intersegmental arteries, so they span the entire cranial to caudal component of basically the neck to the tailbone. And the notochord immediately running through the center of this, dividing the structure into its right and left halves. No, that didn't fix them. Try this. So better. Then we orient to the segmental portion related to the myotome, and we can see that the myotome is related to a cell sparse and a cell dense portion of the sclerotomes. We note that cranial is toward the top and caudal is toward the bottom. So the cranial cell sparse and the caudal cell dense portions with intersegmental mesenchyme represented in association with the intersegmental arteries. And this is true all along the way throughout the trunk region. Now as we go to panel C, we'll see a transverse section of a 5-week embryo, so 1 week later, that'll show the condensation of the sclerotomal cells, the cranial and the caudal components relative to the notochord and the neural tube, and the early signs of a mesenchymal vertebra. It hasn't differentiated into the cartilage yet. And then panel D will be frontal section showing the vertebral body as it forms from the cranial and the caudal halves, as we said. So cranial and caudal half are somehow going to come together, especially here close to the notochord. And of course we know dorsal to that is the developing spinal cord of the neural tube. The intersegmental arteries will have a special relationship with that, of course, and the spinal nerves will also be appearing segmentally in the space basically left behind. So here then we see the mesenchymal vertebra, the vertebral body surrounding the notochord. And this is a solid column of mesenchyma with, of course, localized condensations for each intersegmental vertebra that's going to form the vertebral body anteriorly. You see the early signs of the transverse processes. The neural arch is laid down in mesenchymal condensations, and the spinous process, primordium, also is evident. We see that the myotomes are beginning to take on their elongated orientation from dorsal to ventral. Many of the muscles of the trunk have this type of orientation. Just picture the abdominal muscles forming these bands of muscle, and of course the intercostal muscles being the same. So the myotome is beginning to lay down the musculature in that way. Neural crest cells have already sent their central process invading into the developing spinal cord. The efferent motor neurons have also sent their axons growing out, and as the peripheral process of the sensory neurons and these efferent motor neurons extend themselves, grow longer, there are neural crest cells, as we'll discuss later, that accompany them and form the satellite cells and the Schwann cells that surround all of these nerve fibers. So the innervation is established very early in this fourth and fifth week. If we again take a look at a horizontal section through the same plane as we'd seen before, we recognize the cell dense and cell sparse portions. Cell dense and cell sparse, cell dense and cell sparse. Oops, wrong way. Cell dense and cell sparse. So originally this cell dense and this cell sparse were in one segment. At the point of the junction between the segmental cell dense and cell sparse mesenchyme, of course, is where the mesenchyme cells will differentiate into the fibrocartilage, and the notochord within there will persist and differentiate into the nucleus pulposus, where the notochord is within basically the vertebral body of the vertebral column. Those cells simply will disappear. So the neuron processes, sensory and motor, have a segmental arrangement because they are between the cell dense and cell sparse components of each segment of mesenchyme. Of course, it would have to be because the nerves have to pass between the vertebra, the adjacent vertebra. And the intersegmental arteries still have their orientation right at the intersegmental portion where the cell dense of a cranial and the cell sparse of a caudal adjacent sclerotomes have joined together to contribute to this mesenchymal vertebral body. And we're looking here just at the anterior view, seeing the vertebral body. So the sclerotomes, of course, give rise to the vertebral column. Let's continue this discussion of the development of the vertebral column. We have a basic picture of it, a good feel for it now, and we'll talk about it in a little more detail, especially the formation of the vertebral arch, because this is very important clinically. So the cells surround the developing neural tube and form the vertebral arch. I called it the primordial vertebral arch because it's a mesenchymal model or molding system that is there first. There will be mesenchymal processes in the body wall that will form the ribs, so we can picture where our ribs are, and the mesenchyme just condenses and lays down the earliest framework or molding from which, there would be vascular invasion and the contribution of the osteoblasts and osteoclasts, as we had mentioned before. Ossification will begin. It's incomplete in the vertebral column until about age 25, and this permits the growth of the vertebral column as the spinal cord grows, but of course the spinal cord will stop growing before the vertebral column stops growing, so that ultimately the spinal cord does not fill the entire length of the vertebral column. Well, here we are back at this 15:7, and we remind ourselves of the process that is occurring. The mesenchyme is going to come together in adjacent sclerotomes and lay down the molding of the vertebra, not only the vertebral bodies, but all the remaining portions of the vertebra. First is a mesenchymal mold, as we had said, shown here in panel A at about 5 weeks, so a mesenchymal vertebra. And then, as we said, typically with the vascular or the angiogenesis, the development of the blood vessels, we'll have the triggering of the chondrification centers at an area surrounding the notochord and close to the junction of the vertebral body with the neural arch and within the neural arch. So obviously this is an endochondral type of bone formation. As the vasculature becomes more well established, then primary ossification centers begin as well, and you note that the cartilage surrounding the notochord, or the remnant of the notochord, is one of the primary ossification centers in the vertebral body, and the second location for primary ossification centers is at the junction of the neural arch with the vertebral body. Note that it's still a mesenchymal mold in the most dorsal portion of the neural arch. That will not become ossified until a later stage. Panel D, let's find it, is going to show us a typical thoracic vertebra at birth. The 3 bony parts, we'll point those out. The cartilage between the halves of the vertebral arch and between the arch and the centrum, the neurocentral joint, as we'll see, are present. And then in panels E and F, we'll look at 2 different views of a typical thoracic vertebra at puberty, showing the locations of the secondary ossification centers. So here between the vertebral body and the foot upon which the neural arch rests upon the body, called the pedicle or pedicel, is referred to as the neurocentral joint. And we have ossification of the centrum of the vertebral body, as well as the transverse process and the first portion of the neural arch extending dorsally, but it's still cartilaginous at their future point of fusion through ossification. This will ultimately ossify, and we'll talk about that in just a moment. At puberty, we see that there's still secondary ossification centers at the rims of the vertebral body, the superior and inferior portions of that, and they're called annular epiphyses. So these are epiphyses, just as we had described in the long bones, same type of ossification occurring there, as well as on the transverse processes. Here, of course, in the thoracic region, it would be in association with the rib, the only location where you find the costovertebral junction. It would be right there. If the arrow will move over there. So we know that that is an articulating joint. It is partially movable. It is movable. So that differs on lumbar and cervical vertebra. But these still will be secondary ossification centers there. These are points of muscular attachment in the other regions. And so any force acting on these developing bones is going to control, or the physical presence of something in the area, like in the cervical region, the vertebral arteries end up in the transverse process area. So there would be a foramen there because the artery was there first and the bone formed around it. So there are externally acting forces on these secondary ossification centers that contribute to the overall growth. So we all know that we don't grow, as we grow taller, we don't grow additional, in our trunk as we grow taller, we don't grow additional vertebral bodies. The vertebral bodies we have just get larger. So these secondary ossification centers are important for that. So I guess we'll talk about the final fusion of the neural arch when we talk about the developmental anomalies. Continuing with the discussion of the axial skeleton, again, the axial skeleton is the skull and the vertebral body, the sacrum and the coccyx being included in that. Everything else is the appendicular skeleton. I forgot the ribs. Ribs are axial skeleton. So the appendicular skeleton is the skeletal system dedicated to the upper and the lower extremities. The skull develops in quite a complex series of events with mesenchymal cells of different origins. It is complicated, and we find ourselves again in a situation where we're just going to spend a brief period of time on it. So our level of expertise is at the scratching of the surface, if you will. So let's try to pinpoint a few ideas about this, concepts that we can hold within our memory and appreciate the highly complex development of the rostral end of an organism. The opposing end, you just need a few holes for things to work. At the cranial end, you've got to have very sophisticated structures as well as to encase the brain and leave room for the brain to grow in size. Not an increase in the number of neurons, but in axons and dendrites and the glial cells that are surrounding them. So there first have to be a specific ossification of sequences. Get the base of the skull set first, the center of the skull, sphenoid and ethmoid put in place. So you've got that strong connection to protect the brainstem and support the head, and then the rest of the ossification can occur in the facial region and to enclose the cranial cavity. So the cranial bones will follow those of the core bones, if you will. Allow me to use that term. The bones are connected by immovable joints, the sutures. So this is not a lecture in arthrology, but we remember that basically there's immovable joints such as sutures and movable joints such as the articulation of the rib that we had mentioned and many more, but these are all that we'll deal with for now. These sutures early on are not complete. The ossification is not complete. There's simply a membrane in the area separating the subcutaneous and muscular areas of the scalp from the intracranial structures. And these are the soft spots, as we know, the fontanelles. There actually are 6 of them, and we'll see where they occur. This incomplete fusion of the plates of bone forming the skull and the thicker bones forming the, thinner bones forming the roof and sides, walls of the cranial cavity, and the thicker bones forming the base of the skull and the maxilla for the oral and nasal cavities, allows for deformation and movement of the head. And we all know that during birth, the movement through the birth canal requires a little bit of squashing of the head, and there's a molding of the head just at birth. and an unmolding over the next week or so after birth. So the little beanie that fits the baby's head in the first week just might not reach down to the ears in the second week as things go back into place. So if there is early or premature ossification, that is not a good thing. I wish I had copied this legend and pasted it on a farther along panel of this figure 1519, because we don't need it until then. But again, we just want to gain an appreciation for what's happening here and try to find a few points that we can memorize and at least have the basic concept of this complex system of development in our short-term memory, if not long-term memory. So there's going to be a cartilaginous neurocranium. Obviously, this is the earliest portion. There will be a membranous neurocranium, a cartilaginous visceral cranium, and a membranous visceral cranium. So obviously, the visceral cranium is going to be more associated with visual, auditory, olfactory systems, helping us to orient our viscera toward the environment. Survival that requires ingestion, especially for the major component of life to mention here, requiring this complex rostral component of organisms. So there are several different structures that arise: trabeculae, crani, these two little cartilaginous components forming toward the, let's see, this is looking at the base of the developing skull. So these are toward the nose. The ala orbitalis, obviously near the eye, ala temporalis, the hypoglossal cartilage, hypophyseal cartilage close to the hypophysis or the pituitary gland. So we want to form this base of the skull. We see the paracortal cartilage beginning to develop part of the occipital bone to protect the brain stem, and then the portion of the temporal bone that is going to encase the auditory system, vestibulocochlear system as well. So the otic capsule is beginning to develop there. And then we begin the segmental arrangement in the cervical region for the occipital sclerotomes, and the notochord is present throughout. A bit later on, in 7 weeks, we see the trabeculae are fused, the nasal capsule is beginning to form here, and all of these structures are beginning to enlarge. The hypophyseal cartilage is becoming more complete. It forms, as we all know, a saddle-shaped structure that surrounds the pituitary gland, the sella turcica. Immediately subjacent to that is the body of the sphenoid bone, and the depression in the saddle is the the hypophyseal fossa. So the pituitary gland is encased, at least on its anterior and posterior, lateral and inferior portions, in this cartilaginous model first, but ultimately in bone, the sphenoid. The sinuses are going to be developing in here as well. Within the body of the sphenoid is the sphenoid sinus. So there's many complex things going on. Again, we're just noticing that we protect the base of the brain stem, the pituitary gland, of course, the cranial or rostralmost component to begin to lay down the key structures that link together the entire facial and cranial components of the skull, and all the special sensory organs are gaining their relationship with the early primordia of the bony structures. The occipital cartilage is going to differentiate at least in the first 2 cervical vertebrae, the atlas and the axis. So that's not typical of the remainder of the vertebra. Looking again at the ventral view, and this is C, so at 12 weeks we jump up 5 weeks, and there's a fusion of all this cartilage. The occipital bone is developing first, the sphenoid is well on its way, and the frontal bone and ethmoid bones are developing very rapidly as well. So we want to take care of the base of the skull, get it attached to the vertebral column, and then later we can take care of the cranial cavity. But these don't all fuse together tightly because, as we said, it has to be flexible to pass through the birth canal. So at about 20 weeks, we see most of the fetal skull shown here. The frontal bone is pretty well established, parietal bone, occipital bone, the petrous part, the thick rock-like part of the temporal bone that encases the nerves, the 7th and 8th cranial nerves, as well as the inner and middle ear cavities. The flat portion, the squamous portion of the temporal bone, the incus, stapes, and malleus, the small ossicles of the middle ear cavity have all developed, and they have different origins, which we'll look over, but just do our best to remember what we can on that. And then the oral cavity related structures, the maxilla and the mandible, are developing as well. So this dark red color is the membranous viscerocranium. So these are forming from the, in part at least, from the mesenchymal cells of the pharyngeal arches. So mesenchyma that differentiated from the neural crest cells. The cartilaginous viscerocranium is shown here in the lighter blue color. So these viscerocrania are related with visceral functions, eating, breathing, smelling, and orienting to the environment, and they have a special origin from the pharyngeal arches. So we now have a better appreciation of the formation of the base of the skull, the floor of the cranial cavity, the protection of the major sensory structures, development of the oral and respiratory cavity, bony structures. Now what about the calvaria, or the roof of the cranial cavity? It is more delayed, as we know, and the spaces between the bones simply have that membranous structure separating the subcutaneous muscular compartment of the scalp from the intracranial compartment. And these soft spots, or areas of just a membrane rather than the skull, are called the fontanelles. And at the newborn stage, the neonatal stage, they are still quite obvious, very palpable. You can, palpable meaning to touch and to feel them, their boundaries, and so on and so forth. So there's anterior, posterior, anterolateral, or sphenoid, and posterolateral, or the mastoid fontanelles. So 1, 2, 3, 4, but a couple of them are paired, as we will see. The anterior, where the two parietal bones and the frontal bones meet. We'll look at this in an illustration, an actual neonatal skull in a moment. The posterior is where the occipital and the two parietal bones meet. The anterolateral, where the parietal, frontal, and temporal and the sphenoid bones meet. So this anterolateral is a very important area, as we'll see. And the posterolateral, where the occipital, parietal, and temporal bones meet. You're prompted to draw the superior aspect of the calvaria of a newborn and label the fontanelles, sutures, and bones. Obviously, we provide that line drawing, so you will not have to draw it yourselves. So let's take a look at these features from a superolateral view of the neonatal skull. First we orient, we see the frontal eminence, the parietal eminence, the occipital bone will be back here. So these are the three major bones of the roof of the cranial cavity and the most of the walls. So frontal, parietal, and occipital. We notice that the two frontal bones develop separately, and they do have a suture in between them. It is more closely fused in the anteriormost portion of the forehead, let's say, and then spreads as it approaches the parietal bones. And of course, that junction of the two frontal bones and two parietal bones, where all four of them come together, is the anterior fontanelle, the largest one that most of us are familiar with. But where the frontal bone, parietal bone, temporal bone, and sphenoid bone come together, we see there's the anterolateral or the sphenoid fontanelle, and the identical structure would be on the opposing side, so this is a paired one. Upon fusion of this, forming the suture, becomes what's called the pterion, the P-T-E-R-I-O-N, and just internal to this joint, this junction, where the sphenoid fontanelle becomes a permanent suture joining all these bones, is the middle meningeal artery. So clinically, it's a very important landmark throughout life. You know, the classical case study is somebody getting hit beside the head with a baseball bat and ending up with a severe intracranial hemorrhage because the middle meningeal artery had ruptured. The posterolateral or mastoid fontanelle, shown on the right side here, is paired. There would be, one on the left as well. And this is where the temporal and parietal bone will be coming together in this area. The mastoid portion here, the thick portion, and the squamous portion of the temporal bone shown here. You can see that the facial bones are quite well developed, as well as the maxilla and the mandible. From a directly superior view, then, we can easily see the large anterior fontanelle, identify its margins. I failed to mention that ultimately the suture between the two frontal bones will disappear, and I have to go and look for the name of that. It's called the metopic, M-E-T-O-P-I-C suture, and it is rare to see that persist into adulthood as an actual suture. It typically completely disappears. So we can see the coronal suture between the frontal bones and the parietal bones. We can see the sagittal suture between the two parietal bones, and we can see the posterior fontanelle at the junction of the two parietal bones, and as well the two occipital bones. Also, that suture disappears through development. And the lambdoidal suture is between the occipital bone and the two parietal bones. So the posterior fontanelle was the final one that we needed to see on this. And we end with this slide. We can see the frontal bone identified up here, the prominent anterior fontanelle, so we know this is anterior or rostral toward the nose. So these would be frontal. This would be occipital then. Parietal bones, the major plates over here. The anterior fontanelle at the junction of parietals and frontal bones. Posterior fontanelle, junction of the parietal bones and the occipital bone. We can see, although it's out of numerical sequence, that this looks like lambda. That's why this is called the lambdoidal suture between the occipital bone and the parietal bones. The coronal suture is shown here, forms kind of a crown between the parietal and the frontal bones, and the sagittal suture between the two parietal bones is shown in the immediate dorsal midline. And then there are these couple of slides to show you some of the things that hopefully you can recall to short-term memory for answering some questions. So we'll begin with the axial skeleton on Wednesday. I appreciate your time and attention.